today we'll have a short and sweet discussion on a high yield topic which is asked recurrently in AIMS. Okay, INI-CET. So yes, we'll start with the first question. A 35-year-old female came with recurrent oral ulcers, joint pains, and hematuria. She had a rash on her face, which is shown in figure. Okay, and her urine showed proteinuria 3 plus and RBCs of 10 to 25 per hyperfield. Her creatinine is 2.1, ANA plus anti-dsDNA 2 plus. How to manage this patient now? They have given a picture of a urine for active sediment and they have given a picture of that patient's face. So how are we going to manage this patient? A. Oral steroids. B. Azathioprine. C. Pulse steroid therapy to be given. D. Belimumab to be given. Okay. So in this question, let's first analyze what is the pathology going on. First, they are given a 35-year-old female a kind of rash, which is the malar rash, typical malar rash. It's been given in the picture, and the patient has recurrent oral ulcers, joint pains, and hematuria. So this fits in the criteria of SLE, systemic lupus erythematosus. And if you see in the urine, it has proteinuria and also RBCs are there. So first, for diagnosing this to be SLE, we need to follow one criteria, which is most important, which is the SLIC criteria, SLICC criteria. So how are you going to remember all these patterns of SLIC criteria here? See. First, let's see what is SLIC criteria for SLE. First is coming on to the face. If the lesions, the rash, malar rash, if it is acute or chronic, acute cutaneous lupus or chronic cutaneous lupus, or hair part, if you see, if the patient has alopecia, which is non-scarring, meaning scars will never form in SLE. But in discoid lupus erythematosus, scars will form. And also recurrent oral or nasal ulcers. Of those ulcers we will tell. Okay. So in the face itself, we have 4 criteria for SLE. Then other criteria if you see, next let's see the coverings, serosal membranes of the lungs, heart as well as peritoneum. So pleuritis, pericarditis as well as peritonitis. All these are serositis. They also constitute one of the criteria for SLE. Next, if you see there, the kidneys are there. Renal involvement, which we call as lupus nephritis. We have so many grades, we'll see it in further classes. Then comes the blood vessels. So within the blood we have 3 components. One is RBCs, WBCs, platelets. Each will contribute one criteria to SLE. RBCs for hemolytic anemia, thrombocytopenia, as well as leukopenia. And just remember, all the cell lineage are getting suppressed in SLE. Okay. Next, joints are there. Joint inflammation, same thing, synovitis. And also, last will be neurological criteria. Neurological, if you see, mostly the neurological involvement in SLE will be psychiatric in manifestations. So, among these clinical criteria, what features if the patient has, it is regarded as an emergency? You should know that. That is the most important thing which you should know with respect to SLE management. What are the medical emergencies in SLE? Okay, yes. Before going to that, we will learn the immunological criteria of SLE also. What is the immunological criteria of SLE? First is the patient should have ANA positivity or anti-double-stranded DNA positivity or anti-Smith antibody positivity or complement complement levels will be decreased in SLE due to excessive immune activation. Complements will be activated, C3, C4, all these complements will be reduced. And direct Coombs test will be positive. Direct Coombs test means hemolysis is going on due to autoimmune cause. So we have seen this in the clinical criteria itself. Hemolytic anemia as one of the clinical criteria. So DCT, direct Coombs test will be positive. Okay. So among this clinical criteria, how many things you need, as well as among the immunological criteria, how many things you need positivity for diagnosing SLE. So in total, if you see, there are 11 in clinical and 5 in immunological. So total 16. Among these 16, if you have total of 4, then it is SLE according to this SLIC criteria. And also among the 4, 1 should be there in each of the criteria at least. Okay. Minimum in clinical, if you see, minimum 1 should be there, and in immunological, if you see, minimum 1 should be there, and total 4 should be there, positivity for SLE. So coming to our patient, let's see. Come to our patient. The patient is having recurrent oral ulcers. So one clinical is fitting here. Next, joint pains, synovitis is going on. 2 is fitting. Hematuria is going on, as well as rash is there on her face. So 4 thing is fitting in the clinical criteria itself. And also in the immunological criteria, if you see, ANA plus anti-DSD. So 2 is fitting here. 4 plus 2, 6 points gain in SLIC criteria. So it is diagnosis is systemic lupus erythematosus. Okay, but they have not asked that what you should do in this situation. So for this, you should know the medical emergencies in SLE. Okay. Now let's see what is happening in this patient. Patient is having proteinuria, hematuria. Okay, but what is that picture denoting? What is it cast that is found in the picture? It is composed of circular RBCs. So RBC cast is there in urine. This is a hard and fast rule that whenever you find any RBC cast in urine, it can be only possible in glomerulonephritis. Not in any other condition you can find a cast. If RBC cast, even a single cast is enough. It is glomerulonephritis happening. Because only the glomeruli is inflamed, the RBC is passing through that inflamed glomeruli, will tunnel through that inflamed glomeruli and passing through the tubular lumen, it will form the shape of the lumen, forming the classical RBC cast. That is there, it's 100% glomerulonephritis. And the patient has proteinuria also, hematuria also, so it is lupus nephritis happening in this patient. Okay, lupus nephritis. This is a medical emergency. So if you find a medical emergency in SLE, what are you going to do with? Are you going to give him some oral steroids or injectables or any monoclonal antibodies? This is our question. So let's see the options. Oral pulse steroid therapy, belimumab. Here, since this lupus nephritis is a medical emergency, if you don't treat this lupus nephritis, the kidneys will progress into chronic kidney disease instantly. This is a rapidly progressive disease. Okay, so it is a must that you should suppress the whole immune system by giving enormous amount of steroids. 1 gram steroids you should be giving, methylprednisolone. That is called pulse steroid therapy. Okay, so for that, know the medical emergencies in SLE. If it is a lupus nephritis characterized by proteinuria, hematuria, and RBC cast in urine, it is lupus nephritis, go for pulse steroid therapy, 1 gram methylprednisolone. For 3 days we'll be giving, then we'll change it to oral prednisolone, 1 mg per kg per day dosing mein will be continuing till the flare up is reduced. And also What is the one more medical emergencies in SLE? Central nervous system involvement. Central nervous system, what I told in SLE, it will mostly manifest as neuropsychiatric manifestation. Whenever the SLE patient having altered behavior, psychotic behavior, delirium, in such cases you will give pulse steroid therapy. Shouldn't be thinking to give some antidepressants, antipsychotics. No. It is a must to give pulse steroid therapy to avoid the progression of the disease in central nervous system. Next, what is the one more emergency? The blood parameters. What is it? Pancytopenia. We are discussing leukopenia, thrombocytopenia, anemia. If all the three coexist in SLE, it is a medical emergency. There you should suppress the immune system by giving lots of steroids, 1 gram steroids. Because in SLE, lot of autoimmune attacks is happening against your own RBCs, WBCs, platelets. So it is high time to suppress that immune system with high dose of steroids like pulse steroid, 1 gram methylprednisolone, and suppress the progression from happening. Next, fourth indication is autoimmune hemolytic anemia, which we discussed already. So autoimmune hemolytic anemia, what is the characteristic change it will be there? Direct Coombs test will be positive, and also patient will be having anemia, hemolysis features like hemolysis happening. So the patients will have increased unconjugated bilirubinemia, and LDH from the RBCs will be raised to the circulation. LDH will be raised. Okay, and serum haptoglobin will be reduced because haptoglobin is a protein which will bind the hemoglobin, free hemoglobin in circulation. So normally haptoglobins will be normal in circulation. But in hemolytic anemia, what will happen is, since the RBCs are lysed, the hemoglobin escaping into the circulation will be bound by the haptoglobin. So thus, the haptoglobin levels will become reduced. It is also a parameter to decide hemolysis. Okay, so 4 indications for pulse steroid therapy in SLE. It's a high yield area which is recurrently asked in AIIMS. Neuropsychiatric manifestations, lupus nephritis characterized by hematuria, proteinuria, RBC cast, pancytopenia, and also autoimmune hemolytic anemia. We'll be giving pulse steroid for 3 days, followed by oral prednisolone till the flare-up is reduced. So in the options, what are you going to choose? It's nothing but pulse steroid therapy. We give it. Okay. Yeah. Hope you found this discussion useful. Furthermore, high yield questions in the upcoming session. Thank you.
Best training, peaceful environment, PG medical entrance exam preparation were my expectations. I got them at Speed Medical Village in Kanchipuram. Today, I am a PG topper.
Speed Medical Village, a unique eco-friendly campus dedicated for PG preparation. Speed Medical Institute, a complete solution for medical education.